Good morning, everybody. It's 9:30 a.m. It's good to be punctual. Really nice to see so many people here. I hope it says that I am Carolyn Downs, which I am, and I'm chairing the meeting for today. And welcome. I think I'll start actually just by introducing our new chair of the board, who's only just started yesterday, so I felt that it would be a little inappropriate for him to be thrown into the deep end immediately, but here he is Tom Hayhoe, welcome Tom, and I'm sure that you'll all be very welcome to have a chat with him at any point during today at all. So welcome to Tom, and thankfully he'll be in the hot seat in March.
Well, thank you very much for not putting me in the hot seat.
yeah, lovely. And I think I should also welcome the Deputy Andy Howell to the meeting, who is one of the new Assistant Health Ministers, so you're very welcome, Andy. And also say hello to Deputy Karen Wilson, who's present as well. So anyway, so everybody is very, very welcome today, and we'll get kicking off with the agenda. So Emma, have you got any apologies? I know you have.
We have apologies from Professor Simon Mackenzie. Beverly Edgar is here with us until midday.
Okay, and just for people's information, Claire Garada is actually online with us today, so there she is. Okay. Any declarations of interest from anybody for the items on the agenda? No? Okay. So we have the minutes of the last meeting. Is everybody who's here happy that they are an accurate record? I do know that Claire Garada has actually made some minor amendments to the minutes, which Emma will take on board.
Absolutely.
They're not of a major change that people would need to be aware of. So with that, is everybody happy to approve the minutes of the last meeting?
Yes.
Yeah, excellent. Thank you very much. And then we've got the action tracker for the matters arising, and helpfully following our last meeting, Emma has said when each item will be brought forward to our future meetings, so we don't need to go through all of those, we can take them as read. Are there any items that are open, that are left open, Emma, that you think you need to raise today?
I think in reference really to board matters, action 118, so following Tom's appointment, Tom and Claire will meet in the future to discuss the frequency of the rheumatology reports that will come back to this board. It was discussed at the Quality, Safety and Improvement Committee yesterday, and we'll be receiving a verbal update later on as well on the agenda. One of the other actions was around the terms of reference, so action 108, so the board was to see the Royal College of Surgeons review terms of reference. This was around kind of emergency surgery provision. They've since become available since the pack was produced, so if the board's happy, I could add those as an addendum after this meeting. Okay, lovely. Thanks very much indeed. So we can move on, and we'll go straight on, therefore, to your report, Chris. And I think Jason Whitfield. Oh, there you are. Jason Whitfield, who your job title is the Chief Information Officer?
Chief Information Officer, Government of Jersey.
Right, lovely. Is here as well to update on an IT failure that we've had. But anyway, over to you, Chris.
Yeah, thank you, Chair. So before I go through my report, welcome, Jason. We've spent a bit of time together over the last week or so. The board will be aware that we had experienced an IT incident on Friday the 23rd into Saturday the 24th of February, and Jason, as the Government Chief Information Officer, has been working with the teams here, particularly Claire Thompson, around that. And I just thought it would be very important, although it received some media attention, but just important that the board were aware of what went wrong from a technical point of view from Jason, but also how we responded in HCS as regards to business continuity and our business continuity plans, which are set to deal with such incidents as this. But Jason, just to say, don't get too technical, but just explain what went wrong and what we're doing about it.
Thank you very much, Chris. Thank you, Chair. So we will be submitting a detailed report. The investigation has just really started because of the seriousness of the incident. So this is a preliminary playback of the findings, the facts that we have so far. So in summary level, on Thursday the 22nd of February, the afternoon and the evening before a major incident, my team applied a fairly regular update to our server systems across the Government of Jersey from a third-party software provider. Just to give context, we probably process about 200 to 300 of these on average per year without this sort of level of criticality and incident. So it's far from expected. On Friday morning from 8 o'clock, when the HCS users started logging on in volume, so when the system started to be hit with large numbers of users, our service desk, our help desk, started being inundated with calls, quite simply saying the users couldn't log in. The effects of the problem were like the system was switched off. So like a power failure type incident. It wasn't actually that, the server just wasn't responding. We raised a P1 incident, priority 1 incident. That means that myself and my management team and all the engineers are immediately called into a kind of red alert status to recover it. The first action that was taken was to switch to our backup server within our data centre. And Government of Jersey, we have 2 data centres, fairly standard for an important operation, so you have a prime and a backup that mirror each other in case of problems with hardware failures, sometimes natural disasters with floods and things. So in the morning of the 22nd, we switched within data center 1, the health service workload, so the applications moved to the backup, and surprisingly that didn't fix the problem. We thought it would. The engineers carrying on investigated. We had a number of data analysis, and quite a large team was on the incident all of Friday morning. We were unable to find the root cause of the problem. We were of course talking to the third party that provided the software patch, the upgrades that we applied Thursday. So we then evoked the next level of recovery, which is switching to the backup data center. That also didn't resolve the issue. That was when it became a critical incident. And at the time, myself and my leadership team were evaluating a full backup recovery, which I'll talk about in a minute and explain what I mean by full backup recovery. We were working closely in the hospital with Claire and team, and we were evaluating all the options, and I think Claire's going to speak in a minute about how we made a decision to move into business continuity, so more manual processes that Claire can explain. Which actually was one of the few positives of a very difficult incident. We actually exercised that very well, and the teams worked very well together, and Claire and I have talked quite a bit about that since. So, of a problem, our business continuity process was tested and was successful. It's just something I'd like to comment on. We still don't know the root cause of the software. The system software is monitoring software, so we've halted using that software for at least 2 weeks. I'm working very closely, as you'd imagine, with the third party that provided the software and the patch. They're a large worldwide organisation, by the way, and they haven't had this issue with any other customers. We weren't the first customer to have this update, so anecdotal information at the moment implies that there's something special about our technical environment that has caused this problem to happen. And we're investigating that. Normally it would take 1 to 2 weeks for the engineers to be able to diagnose that fully, and for me to report back to you here on the real root cause of the issue. So right now we don't know the root cause. We sincerely apologise for the inconvenience. It was a very difficult day in the hospital, and we're thankful for Claire and her team working with us on the business continuity.
Thank you, Jason. Claire, do you want to say how, because unfortunately or unfortunately, I wasn't on the island at the time, so Claire took charge and implemented the business continuity. Do you want to say how we responded? Because this is important as regards to patient safety and other things like that.
Of course, happy to. So yeah, as described, obviously we had those issues reported from staff. They were feeding into the operations centre, which is our control centre that we use every day, just to ensure that we're managing any issues, whether that's staffing difficulties, capacity, etc., etc. We'd already described that the day was going to be difficult from a bed day, so we were in a black escalation, which is our usual policy of describing when we've got concerns about a potential demand outstripping capacity, that we know of that position. I suppose as you go through the day you get informed of more discharges, so you're constantly reviewing that. However, we knew it was going to be a difficult day from beds, but obviously that process was followed as normal. Obviously, we started to then work closely with our MD colleagues who, as Jason, were in the operations centre, which really, supported us being able to have very close, very continuous conversations about the issues that we were facing, and we'd instigated increased bed meetings because of our capacity issues, but obviously our incident process stepped in, and obviously those ensued throughout the day. I suppose around lunchtime we were aware of the cumulative effect in key clinical areas such as theatres, and just after about 12:30, on recommendation from the medical clinical lead in theatres, we made the decision to cease routine surgery at that point because of access to IT to be able to do the job. So the impact that has is it obviously, unfortunately, we had to cancel some planned surgery that day, but obviously allows patient care to continue safe because we've reduced our demand, and of course at all times we maintained our ability to treat patients in ED, maternity, and ensure that we had emergency theatres available and running, and whilst obviously staff's working environment and usual working was affected by this, as described, we implemented our business continuity plans. On some of the wards, then sort of around 11 to 1 p.m, they had already started to implement business continuity plans around our electronic prescribing, which was the main thing really that affected us from an IT point of view in terms of inpatient care. So some wards were managing to still continue to use the electronic prescribing because they had access to it, where other wards had lost that ability. When we were informed around the likely timeline for getting resolution and confidence of resolution being sustained, obviously that was emerging that this could be something that could go into the weekend. So due to us moving to an out of hours period, with obviously support from my executive colleagues and all of our teams within the care groups, we made the decision to go to move all inpatient wards onto business continuity plans, because as people know, patients do move around the building, rightly so, to specialty wards, and we wanted to reduce the risk of having different staff working with different processes. We stayed on business continuity plans for our electronic prescribing until the next day, and obviously by we had confidence of resolution as we went into the night, 6 p.m, 10 p.m. We were obviously then getting reports of staff able to access the system, so we could have gone back to electronic prescribing at that point, but the decision was made to hold the position, get confidence of that resolution, thereby reducing risk to patients and staff, and then that was all reverted back to electronic prescribing around 2 p.m. the next day when we had that confidence of resolution. And even impressively so, we managed to then, due to the hard work of all our staff, actually we ended the day being into a plus 18 bed position, as we'd obviously followed our escalation process, in terms of managing beds and capacity and demand. So we've got a debrief plan for next week, which is usual practice in terms of major incident, and again I'm sure they'll be learning from being able to use and test our business continuity plans. But in terms of patient safety, no concerns have been raised. We recognise obviously it's a challenging day. Our staff prefer working with the IT systems that that we have. There were 34 patients affected on the day, predominantly outpatients that had to be cancelled at very short notice, and clearly we apologise to patients that are affected. There were 7 patients in day surgery and 3 in main theatres. All of that inpatient activity has been rescheduled, and predominantly all of the outpatient too.
Thank you. So no reports of harm that came through Datex or anything?
Thank you.
Thank you, Jason. Thank you, Claire. Okay, so as I say, I wasn't expecting that when I wrote this report, so that was an additional item.
Yeah, please do, Jason.
Thanks, Jason.
Thank you very much.
As I say, I in some ways take my report as read, but I will highlight some issues that I think are important. The The first is, and again, the board are aware of this, that there was an inquest which was concluded on the 2nd of February this year. And you'll see in my report that what that was about. It did receive quite a lot of the media attention, so those people that look at the media will be aware of this already. Following the inquest, which took 4 days, the relief coroner concluded that Mr. Watkins, and I say his name is obviously in the public domain already, had died of natural causes but contributed by neglect relating to aspects of care and treatment provided to him in his final days. This was back in August or the end of 2021. The coroner, or the Viscount, noted the work that had been undertaken since this sad death around addressing some of the weaknesses that contributed to this issue. And a bit later on in the agenda, we have an item on the mental health improvement plan, which Andy Weir, the Director of Mental Health and Community Services, will take us through, so I won't do that now. Cultural change, as the board knows, this remains a key priority for us, and we have mentioned the programme that's called Civility Saves Lives. We launched that campaign in January, so last month, and that launch was attended by about 240 staff across HCS at all levels, doctors, nurses, allied health professionals, management teams. We also have focused on bespoke interventions from the Civility Save Lives programme to those areas that we believe required and deserve some bespoke attention as regards to cultural change. So that also happened during January. We're going to continue to look to embed this programme across HCS during the course of the year as part of the organisational development interventions that we're making, so that we can focus on how staff can respond and manage inappropriate behaviours, how we can ensure that some of the real issues around culture within HCS are addressed. As I say, I've always said this is not an overnight fix. Cultural change takes time, but we started last year and we will continue to embed that during the course of this year. Leadership as the Be Heard engagement factor was an issue for HCS last year, the survey that was taking place, and I think many of the board will be aware that the Be Heard survey is a government survey which includes things like leadership, and we scored very low on that last year. Government of Jersey Leadership Development Programme has now commenced, and in early February I, along with my executive colleagues, attended the development programme. Other senior leaders in HCS will also attend future cohorts of that programme. We're also developing a leadership development plan for other leaders in the organisation, including our clinical leads, which are basically consultant medical staff. So leadership development, a key factor and programme during the course of this year. We also have been focusing on supporting diversity and inclusion. This is a particular issue that we have. There's no hiding it, and I've mentioned before that we do see discrimination happening within HCS from patients, public, and indeed between staff in HCS. This is something that is unacceptable and intolerable. I will not allow this to happen anymore, and we have to face up to the fact that this is something that is plaguing us and we have to deal with it. We've had a number of conversations with staff about this, and we had a very well attended Teams talks, and just to remind the board, that's meetings that I have over Teams with staff, where we heard stories about how our ethnic minority colleagues are treated, and it would make you weep to hear some of those stories. We have to tackle it. We are going to be launching an anti-racist statement as part of our race equality programme And that statement, along with a survey that we've recently undertaken about this issue, will come to the March board. So this is again part of our cultural change programme, and it's something that we need to be rid ourselves of. If patients are to receive the best care, discrimination results in poor care for patients. There's plenty of evidence around the world about that. Workforce, so you'll see on the workforce report, it's been pretty consistent. Vacancy rate is around 17%, similar to previous months. Our voluntary turnover rate remains consistent around 4%. This is very low compared to the National Health Service, probably 3 times less than you'd expect to see in parts of the NHS. So again, that has been consistent. Sickness, we've seen a bit of an uplift in January, I suppose no surprise there, and you'll see that sickness has really contributed to coughs, colds, flu, gastro problems, and a seasonal issue, but I guess no surprise. I will let Bill speak about some of the other things that we're doing. Bill Nuttall, our interim workforce director, around recruitment, because of course speeding up recruitment, improving the recruitment process is vital from all levels of interest, both clinically and financially. Financial recovery programme, financial year 23, we achieved the savings. We had a target of 3 million, we actually delivered 3.2 against the financial recovery plan. However, this is going to have to continue during the course of this year. There are some significant challenges that we face this year as regards to savings. The savings we need to make this year are at least £12 million. I think it's probably going to have to be more than that, OB, as we uncover further pressures. So there are a number of dependencies in delivering that, both from HR and procurement, and we're working with senior colleagues in other parts of government to secure that support. So as this report says, any delays in receiving that support and being functional by the end of this month is likely to impact and have slippage on our programme. The financial, there's no finance report this month because that's in line with normal Government of Jersey timetable. They've got to complete the year-end accounting and reporting processes and indeed the audit timetable. So we won't see the formal 2023 outcome until early May, including obviously the financial performance of HCS as part of the government. However, we're very aware that a number of risks materialised at year-end, leading to significant additional cost pressures that we were not forecasting, and again, those will be reported once the government timetable for accounting has finished. Financial results for month 1 and 2 will be available again also in March, and this is a product of the government processes and financial systems that we have, that we don't see financial results for the early months of the year, which is not something I'm used to. But you know, typically month 1 is never particularly reliable as an indicator, but it's nevertheless not something that is desirable, OB or anyone around this table, but nevertheless that's the situation with us. Clinical governance, and we had the first meeting of the Quality Assurance Committee, as Emma said, and Claire Gerarda is going to probably give us a verbal update because that meeting only took place yesterday, but a full paper will come to the board in March on that. Rheumatology, Dame Claire Gerarda has been nominated as the non-executive lead for the improvement programme for rheumatology, and Claire and I spoke about that yesterday. You'll see the maternity improvement plan is in the agenda, and we're still making progress against that plan. Acute medicine will again or the Assurance Committee will have oversight on the acute medicine improvement plan. This is following a report in 2022 by the Royal College of Physicians. As I said, the full details you'll see in a report. It's pretty clear that significant progress still needs to be made with that programme, and indeed that will have quite significant implications on how we configure medicine in the future in HCS. So again, this is a key piece of work, and I would say one of the priority areas that we now need to address during 2024 as quickly as possible. I won't mention anything more about mental health and social care because Andy will pick that up, because there is also a very ambitious development programme in place for this year as well. You'll see the waiting list report as well. Claire will pick that up, but you'll see in my report some of the sort of key headlines with that. Acute services, again, I won't go through this because it's in the report and Claire will pick that up as well, but the summary is there. Patient experience, I think this is a very important part of the work that we're doing now. The patient experience team are now working in partnership directly with the care groups and managers in a more structured way, thank you Jessie, to seek local resolution to concerns and complaints that patients have, and ensure that we manage complaints in line with government policy, because we have to, and establish some key KPIs, performance indicators. There are a total of 64 patient advice and liaison service PALS inquiries logged during January last month, compared to 15 in January, which I hope is, you know, a result of the more proactive work that is being undertaken to identify concerns for early resolution. Remembering it's always best for everyone, particularly patients and families, if things can be resolved prior to sort of formal complaints process, that we can grab it and solve it for patients and their families sooner rather than later. One of the key themes of those PALS concerns were around waiting times for appointments, and again, I don't think the board would be surprised about that as a key thing. We are now reviewing again the process in managing complaints. There's been a lot of feedback about the process, which has been really helpful, and Jessie, we are planning, colleagues,
yes,
to have a big public communication campaign to raise awareness on how patients can raise concerns and complaints, and that is going to take place, and I guess you'll pick that up a little bit more later on. We have seen a noticeable increase in compliments, because of course we also record compliments which we share with staff, because of course sharing those compliments with staff is a great way to boost morale, and we always like to ensure that staff get that feedback. As regards to infection prevention and control, continues to demonstrate low levels of hospital-acquired infection, so that's good. And improving vaccination uptake still remains a challenge amongst staff, as it is in other jurisdictions. It's certainly from my experience, and I guess others around the table, in the NHS, it's a real challenge to get staff to take up on vaccinations, COVID, flu, etc. Tissue viability and falls remain low, which again below the UK average, which is good. And work has commenced on the development of a much needed nursing in midwifery strategy for HCS. So thank you, Jessie, on that. And I think we're expecting that could come to the board in Q2, 3, but through the normal assurance committees as well. There are a number of staff achievements. I've listed them there. It's difficult to always choose which ones to highlight, but I do want to highlight that I did mention that we had a Teams talk around the issue of racial discrimination. 75 staff attended that session, which is good. And we also like to welcome, in relation to our maternity improvement programme, our new director of midwifery and nursing is Rosalind Bullen-Belt, and she started December. And also Bill, I think we welcomed you last time as our new interim director of workforce. The one thing that I do want to raise is I mentioned in my report that someone by the name of Donna Murphy had been shortlisted for the National My Porters Award, an International Porter of the Year Award. Winners will be announced on the 21st of February. They were, and Donna won.
Oh!
So that is a portering award that is national and international, so a great achievement. And Donna came to our executive leadership team, where we also presented her with some some gifts, and to thank her for that. So, importantly, 98, which is again good, HCS colleagues attended a full-day training on something called human factors. Many around the board table know what work that is, which is helping us to recognise and understand and indeed mitigate human factors that could influence accidents or incidents in the workplace. It's something that's used extensively in other health systems. So thank you very much. Welcome to questions.
Yeah, thank you for that, Chris. And I think we would like to pass on our congratulations to Donna as well. That's an amazing achievement to be the International Porter of the Year. And it's really good to raise the profile of Jersey, but it's really good to raise the profile of Jersey health and care system. So she, I think if you have an Employee of the Year, she should be a good candidate for that one. So thanks to her. I think a lot of the items in here are actually on the agenda. So if there's anything that isn't, Tony, that you want to raise?
Yeah, just briefly, thank you, Chair. And for those who haven't met, I'm Tony Hunter. I'm one of the independent NEDs. I just want to say thank you for that report, Chris. It is that kind of view from the bridge that we're very much looking for, that overview. I mean, we all know we've got a massive improvement agenda in front of us, but you know there's some real green shoots there. I think really it's good to see that voluntary turnover rate at 4%. You know, as you pointed out, I know we'll be going into it later, and also in overview the culture change focus as well, because. But a plea now that, you know, we always think that the people who need to change are not us. You know, it's always somebody else who's got to change. I remember somebody once saying to me, well, the only people who ever really like change are babies with their nappies, and even they're not that bothered really. So I think a dose of humility for all of us all the time on culture change. Thank you.
Thank you.
Anyone else? I had a question because we don't have, Obi, you're there. So because we don't have a quarter or a period 1 or period 2 outturn report, I just think in the public part of the agenda it would be really helpful if you could say how you feel we are doing on that. We obviously have a discussion in our part 2 private part of the agenda, but I think for the public it would be useful to know.
I think we have a good feel for the organisation. Whilst the formal processes means that months 1 and 2 are never reported, it is always in March they report month 1 and 2 processes. That does not mean we do not know what's going on. Usually the financial results are a backward, retrospective look. But clearly the art of management is understanding prospectively what's going on. Whilst I can't give you exact numbers, however, we know that last year we exited with more cost pressures than we had forecast, and there are specific reasons behind that. And of course that carries forward into the new year. We also know that we've implemented a lot of actions, critical control, expenditure, and the FRP programme very clearly describes all the improvements from both a quality, operational, and financial perspective, like reducing time to hire, looking at our large contracts, and so forth. That will make the difference in bringing down the financial position towards budgetary constraints, which we have agreed with Treasury over a 3-year period. The timing of it is what is at stake here. Whilst the improvements I am confident will deliver over the time period of 3 years of the FRP, it is the timing of when those improvements, how quickly they're getting, because there are dependencies in delivering those. Finance is not an item. It simply expresses the consequences of the actions that are taken on the ground by doctors, nurses, operational management staff. It simply is a measure of it. It's a KPI. It just tells you what's going on. And we know, and that's why we have a handle on what's going on the heartbeat. Before the formal numbers come out, I do expect there to be significant risks that will be in our position for months 1 and 2 compared to our budget position. There will be an ongoing overspend that comes through from last year. The exact numbers we will report, but that should not come as a surprise to anyone who understands what's going on the ground. So we don't have to wait for 3 months, that's just formal processing. But before we can give exact numbers, formal numbers, there will be pressures because we know that some of the reductions in those schemes, for example, time to hire, getting people in quicker, recruitment processes. Whilst we've said that retention is good, 4%, we know that not a lot of turnover is happening, our challenge isn't retention, our challenge is recruitment. Our challenge is the time it takes to recruit people, the number of hoops and delays that we have to jump through, the number of people we lose during processes, but we actually have got people waiting to join and are frustrated because we are so slow at them and we leave. But that's our challenge. The sooner we can do that, and that's where we're working very closely with the Director of Finance, the sooner we can fix that, the shorter we can make it, the more that run rate, that financial position will come down, and we know there are delays.
So that reduces our dependency on, as we've spoken about, for agency. Sorry, can you hear me? That reduces our dependency on agency and locums, which of course is one of our major spends, as we all know.
Absolutely, and improves the quality of care and well-being and teamwork. So that is our absolute critical factor.
Thank you for that, Obi. And when you come to your report later, Andy, on mental health improvement plan, I think it would just be useful for you to touch on the inquest and the main learning points from that, if that is okay. So Claire's got her hand up, thank you.
I just wanted to ask, what's the main delay for getting somebody on board? Is it DRB checks?
Hold on, this is a nice one on the agenda later. Can we deal with it under that? Because, you know, Bill's done a full report on it, and so let's do it at that point, if that's okay. All right. So at that point then, can we accept Chris's report? Good. And move on then to the performance report, which is you, Claire, isn't it? Yeah. So what I would say in this is, because we get this report every month, and things don't change massively in a month, so we don't need to go through it all in masses of detail. If there is anything and any trend which is not improving, or you have got a particular concern about, I would like you to raise that rather than just introducing the whole report, if that's okay. Thanks.
Sorry, can I just chair, just to say, because this report now is using SPC charts, statistical process control, which is a normal way of, or a more helpful way of looking at this performance. It's well used throughout the world. It's not unique to Jersey. So SPC charts are important. Anushka, you're an expert on SPC charts, but this is, we're using this because this is what you'd expect to see elsewhere. So.
Thank you. So just some real brief headlines from me. I'm not going to go into lots of detail around elective performance because we've got a separate paper on the agenda, but I suppose just to sort of broadly describe what's visible in terms of our metric now over 52 weeks, in terms of outpatients and the elective waiting list. Obviously we can see where the impact of our waiting list recovery has really impacted those waiting more than 52 weeks in terms of outpatient care, where we've got that down over the back end of last year. Obviously some of those rightly converted to patients need to come into surgery, and we've still got some legacy issues in terms of COVID recovery with some particular specialties, but they are all being addressed by waiting list recovery plans, and I look forward to evidencing at board how they improve in the next couple of months. The DMO1 access to diagnostics is a new standard for us. Obviously I'm not able to describe currently whether we've got the correct capacity to be able to deliver good performance on that, but we'll continue to assess, and that will support strategic business planning as we go forward. New to follow up is improving, so I'm not going to dwell on that. In terms of emergency care, just briefly mention we've implemented holding ourselves to account against the 4-hour target as we go into 2024. That is new. Obviously, whilst it remains a measure of particularly the experience of patients in ED, is actually telling the board and obviously ourselves about the performance of the whole system of care, because clearly we can only admit if we're able to discharge patients. However, it is also a measure of internal efficiencies, both those within the ED department and within the hospital, and there's well-developed work streams that are addressing that as part of our FRP work streams around clinical productivity. We can see that patients unfortunately did wait a little bit longer in the ED department with those over 12 hours, but some of those patients are patients who we were able to return home, and not just those with the decision to admit, but also was describing some of the challenges we had around access to side rooms, particularly as we saw rising flu numbers and other viruses associated with winter. So I think those are the main headlines for me, and obviously we'll focus on the elective elements in the waiting list paper later on the agenda.
Right. Does anybody have any questions for Claire? As I say, the waiting list we should deal with on the next item on the agenda. So any questions on any other parts of this report? I've certainly got one. If anybody else has, I can't see. No. So my question is around operations that were cancelled, and you actually write. I can't remember exactly which page it's on. Sorry, Claire, but on operations cancelled, you put one of the explanations as, and I put it in vertical, patients have not been adequately communicated with. What does that actually mean?
So in terms of our preparation actually for assessing our performance in relation to this winter, we've been pulling some different metrics and data. So in terms of cancellations on the day, which is a metric we're now focused on and monitoring, there were more cancellations due to, I suppose, if you like, administrative issues, so patients being informed adequately with time around the date of their operation, being able to get through our pre-op processes. Actually, there was more cancellations in relation to that than there were bed availability. So again, supporting our planning around winter, but obviously that's a key area of focus around ensuring that we are really swift and smart on all of those areas. So particularly patients saying that they didn't receive a letter, for example, so it's elements of that, but that's all being looked at. We want to be able to develop a choose and book system, particularly for outpatient activity. You can book a plane ticket, your dinner at the restaurant, but at the moment we have the process where we write out and tell patients, this is your outpatient. Of course, obviously for a lot of people we know that won't be convenient because they'll be working or they'll be having other family responsibilities. So where we want to move to is that we will make all outpatient bookings by picking up the phone and speaking to patients, certainly for their new appointments.
Because outpatient, this would be a day operation then that you're talking
about?
And so
day surgery, yes. So we can see in terms of our theatre bookings that people are not turning up, for example, on the day of their operation. So we've never had a text reminder service for surgery, although we do have that in place for outpatients, and we can see where that's impacted our DNAs for outpatients. So with the different booking system around electives, that's something that I will expect to see reduced.
So this is entirely within our hands, isn't it, to fix?
Absolutely.
So it's absolutely imperative that we do fix it,
yes,
because it's just a massive productivity waste.
Absolutely.
Yeah.
Absolutely.
So it will be really good. How quickly do you think you'll be able to impact on that? Because we really shouldn't have that at all.
No, absolutely. So we've got a weekly task and finish that is monitoring these metrics, and I expect to be able to demonstrate some improvements to that next month.
Good, well, I will definitely look out for that one.
I look forward to showing you.
Yeah, brilliant, good, thank you for that. No other question? Oh, sorry, Tony.
Yeah, I know we've talked about this before at the board, and that is the dearth of social care indicators. I think if we get the out of hospital bit right, we get the in hospital bit right, if I can put it like that. Really, we really need to be focusing on a much broader suite of indicators, which are about healthy, sustainable quality of life for people of Jersey, which reduce the need for hospital admissions and encourage safe and comfortable discharge as well. So over time, and I know Rome wasn't built in a day, but we do need to see a much fuller suite of it. And I know, Andy, you and I were talking about this yesterday, and you were giving me a helpful update on where we are with that. And you might want to add to what I'm saying there, yeah?
Well, whilst you're doing that, Andy, if you could answer my question as well, which is the delayed transfers of care this year are far worse than they were at this time last year. So if you could just update on that, thanks.
Yeah, thank you. I think it's just probably really important to note this is an integrated performance report, so there are indicators about mental health and social care within this report as well. And I think we must continuously remind ourselves not just to talk about the hospital. This is a whole system, HCS, not just hospitals. So I entirely agree with you. So I'll do the mental health first, if that's okay. So I'm particularly pleased to report that the crisis team saw 94% of people within 4 hours this month, which is the best achievement that we've had to date. But also that the service continues to achieve the KPI for following people up on discharge within 3 days, which was abysmal previously. And this is a safety KPI. So I think those are particular achievements, and I think the service needs to be congratulated for that. The areas of escalation of concern relate to waiting times for the memory assessment service and for ADHD. We've talked about ADHD previously here in some detail. There's been a vast amount of media information in relation to ADHD and our waiting times this week, so I'm not intending to rehearse that unless the board wishes me to. I'm pleased to report that we had a really good meeting with the Memory Assessment Service last week, where we've developed an improvement trajectory, which is partly redesigning the diagnostic pathway to make it quicker. And some of the staff will be working differently in order to achieve that, but also we've found some additional medical diagnostic capacity to put into the service. I'm hoping that we'll start to see a change in the delays around memory assessment. So that's that. In relation to social care, I agree with Tony. The service has been working on developing other indicators. The board will know, because I've said previously, these are just 3 indicators that sit they're on top of a whole raft of other indicators that we look at every month in the normal governance processes. But we need to agree which other indicators come here for social care. And I think that's a piece of work that we're going to do together.
Sorry, Andy, can I just say, so the indicators that we currently have, to sort of sense that they're not necessarily the best indicators to give us a sense. Yeah. So is that your view?
I think that's absolutely right. I think they're important. So there's only 2 currently now that come here. One relates to physical health checks for people with a learning disability, which is terribly important and wasn't being achieved and now is. So I think we need to keep an eye on that. But the second is in relation to whether or not social care assessments are completed and authorised within 3 weeks. Well, that's a process measure, really, and doesn't tell us anything at all about the work that social care are doing, what's being delivered, where the gaps are. So, yeah, I think there's more work to be done, frankly. So that's that. In relation to DTOC, so we've seen a real change in DTOC. Probably this time last year, and certainly through until the middle of last year, that one of the key issues that we had was around packages of care. And actually about half of the people at any given time that were delayed within a hospital were delayed because they were waiting for a package of care. And very often what would happen was that someone would be assessed, and clearly that sometimes takes time, but then the provider couldn't provide the package of care for a week, for example, and so the patient then stays in the bed for a week waiting for the package of care to be delivered. That was the position a year ago. Really helpfully, that we've introduced a new brokerage system that's managed through customer and local services, where we put out any care package requirement and it goes out to the market essentially, and providers can access the brokerage system electronically. So we're seeing such a speedier take-up now, and actually the number of people waiting for packages of care on a weekly basis is less than you could count on one hand, which is great. The particular problem that we have at the moment is nursing care. So the number of people waiting for nursing care has gone up in the last few months and has stayed high. There's a couple of reasons for that. The first is the availability of nursing care on the island, so that's the first thing. The second is the complex needs of some of the people, particularly people with dementia, where there's a really limited availability of nursing care, and we've talked about that before. And then at the beginning of the year, certainly in January and February, there's been some reduction in the availability of nursing care beds due to either nursing homes refurbishing or closing beds temporarily, etc. So we've seen a bit of a perfect storm in terms of people not being able to move as quickly as we would like. To provide assurance to the board, we meet every week. That's a meeting that either Claire or I chair. It's an integrated meeting of social care, the hospital and community services, so that we can, wherever we can, Chris has been on a number of occasions, wherever we can, that's about making sure that we address issues in the community to move people through as quickly as possible. So we're still going. There's certainly more work to do around capacity for nursing and residential care, but the care package work seems to be working at the moment. We actually thought, this time last year, we thought we were going to have to develop a bridging service around discharge because we couldn't get people's care packages through. We're nowhere near able to do that now.
So when do you think that the performance will improve on that?
think it's very difficult to say, if I'm honest, because a lot of it is out with our control. We're starting a conversation now with care providers, which we've had before, about what needs to happen to move some of the people that are particularly delayed through. The other issue that I haven't talked about, which is particularly problematic for us, is around housing. So at any given time, we have 3 or 4 people who are sitting in the hospital waiting for housing. And at the moment, the longest example of that is someone who is in a wheelchair and could have left hospital in the first week of November. Despite multiple conversations between us and the housing department, senior conversations between us and our customer and local services colleagues, no housing has been available for him since that time. So he's currently still sitting in a hospital bed, despite the fact that, and that's about needing to find housing that is adaptable to accommodate his disability.
But that is really unacceptable for that person.
Absolutely.
Because their health and their independence will deteriorate shockingly, because that's now 3 months, so...
Yeah. So these are the cases that we pick up and we talk about and we seek to resolve. Clearly, we don't provide housing.
No.
In mental health services, we do provide housing, because we've actually reached a point where we now pay for bed and breakfast for people rather than keeping them in the mental health beds.
So is that an issue which is within the remit of the government of Jersey, though?
Yes. So we are working with our partners in the housing department to try and resolve this.
I think that's an escalation issue for press and politicians, to be honest.
Maybe, I can see some enthusiastic politicians helping, looking to help us on that. So I guess, Andy, we could provide you with some further...
Yeah, thank you. That will be good. Okay. So, one last one then, Tony.
Yeah, just made the obvious point, and again, I know we've all talked about it before, but the opportunity we have on the island for an integrated, government-led, people-centred approach to good quality care and support, early intervention and so on is just there for the taking, really, if we seize it. So we're all looking forward to participating in that beyond HCS.
Yeah, brilliant, lovely. Sorry, Claire's got her hand up, has she? Claire?
Just a quickie about physiotherapy. Do you do remote physio? Because it's a very, very big waiting list for people that combine trauma and orthopedics and pain.
I think it's sorry Claire, it's nigh on impossible to hear what you're saying. Did you get that, Emma?
Claire, did you ask about remote physiotherapy access? Was that your question?
Yes.
Okay, that's you, Claire.
So in terms of community physiotherapy, was that the question? So I can...
Yeah.
Do you provide remote physio, i.e. online physio?
Not online.
Yes.
Claire, I think we're losing the connection temporarily.
I'm happy to look
You might just
into
need to
So I think what if the two Claires could have a conversation about that, and we'll put it as an outstanding action on today's coming from today. Something we need to come back on, given the poor connection, if that's okay. Good. All right then. I think on that basis we should move on. Thank you for the report, Claire. There are some issues there that I think it will be really, really important for you to come back and show us the improvements, so the ones that we particularly highlighted. And then we can go on specifically to the report that you have done on the waiting list. Again, on this report, I would just particularly highlight anything specifically that you think that you want to draw to our attention, and then we can go into discussion.
Yeah, thank you. Happy to. So I suppose the key headlines are where we are managing to control the actual size of our waiting list, both in terms of the outpatient and the elective. So we are holding the size and actually reducing the size in volume. We can demonstrate where we have addressed the long waiters, particularly in outpatients. And as I described earlier, we can see where obviously some of that activity is rightly converted to elective activity. In terms of our outpatient waiters over 365 days, Obviously now we've got the focus on the 52 week wait, so we can really then focus and demonstrate our efforts in reducing those longest waiters. We have well-developed plans in relation to that, particularly ophthalmology, so that will be eradicated in the next couple of months, particularly with our plans around that and providing care for cataract patients. In terms of our inpatients, again, focus on those patients who have waited longer than 52 weeks. They will be eradicated in the next couple of months with our WLI, our waiting list recovery schemes, and then we will, in both of those areas, really then focus on those patients which over 90 days in both areas. We recognise that we have significant numbers in there, but that will be predominantly addressed by our waiting list recovery, continuing to reduce our need to follow up, and I think particularly for our inpatients, the fact that in February we have now, even with winter pressures, we've been able to open additional capacity with the new medical ward coming online, which allows obviously then patients not to have to then go into surgical ward, and will allow both increases in public and private activity, which will obviously support waiting list recovery and also our income position. There are some nuances in relation to the current waiting list, and obviously to allow us to fully benchmark. For example, we have patients who are in our elective waiting list that are actually surveillance patients, so they're not patients that are actually waiting for a procedure as soon as possible. They are patients that we know that we need to see in 6 months and a year, and similarly with an outpatient. So we do need to develop our surveillance waiting list that allows us to then really focus on those patients who are on a planned surveillance for 6 months or an annual checkup, both in our elective and our outpatient areas. And again, Jersey's not had the ability to suspend patients, which again is a very normal procedure in a waiting list when we know that someone may not actually be fit to receive surgery now, or they're not available, for example, because they're travelling and they're actually choosing not to have their procedure straight away. So those are all things that we're working on. Obviously there's focus work where we can show delivery on particularly MRI, and then other focuses around diagnostics. Even with the disruption from the IT event on Friday, I'm pleased to report that the insourcing weekend again around endoscopy still happened this weekend, so that by the time that piece of work is finished, that will be nearly 500 patients that have been reduced from the endoscopy waiting list. There's detail around our plans around ophthalmology. Dermatology obviously is an area of risk. That's been predominantly driven by our ability not to recruit into long-standing vacancies, but we have made some headway into that, and we can demonstrate where the routine waits are also now starting to come down. But I think we do need a much more of a longer-term view around our strategy around dermatology. I'm happy to take any questions.
Okay, so I've certainly got a couple. Is anybody else got any questions that they'd like to go first with? So I don't see any. So I think we specifically asked at a previous meeting how whether the new electronic patient record system was impacting in any way on the waiting list, and I didn't see that covered in the report. Okay. So I think it would be useful to get something on that, because there's quite a lot of noise in the system, if I can use that expression, about the electronic patient record. So I think we need to absolutely have assurance that it's not causing delays and not impacting on waiting lists. So that's one that's out in hand. This is probably me, and I just don't understand. So if you look at general, under item 6, main report, your new patient referral PTL, and you've got general medicine, and it starts at only 6 people on the waiting list from 0 to 30 days, only 1 at 31 to 60 days, only 5 at, and it goes up, and then suddenly it's 31 at over a year. And I just didn't understand how you could go from such a low figure at only 30 days and then to be such a much larger figure at a year. So if you could just explain, I'm probably just being a bit thick. But
no. So we can see that this is patients who are offered. So those patients are monitored absolutely on a weekly basis. So every week we have the general managers and the waiting list managers, and we go through and we can see exactly who those patients are. Often these patients are saying they're not available. You know, we've offered appointments, they don't attend. So we absolutely know, and obviously if we've got any clinical concerns, again, we bring them attention to the consultants. Obviously in terms of our access policy, if we have offered patients multiple appointments and they're deciding not to attend, then obviously we need to have a discussion with the clinician themselves about whether they would remain on the waiting list.
Okay, so I completely understand that now. So basically you have been dealing with it all, and then somebody says, I can't make that appointment, so it then goes on to it.
Yes, and these are patients that are often...
I think you need to consider is whether they then, at what point they rejoin the waiting list, as it were, rather than just going to the end of it, you know, so that's their choice. In
I think that's the, Claire, you alluded to what's called suspension, which is a term that patients that said, I don't want my procedure now, I want it next year because this year I'm
going on
in
holiday.
college or on holiday or whatever, that rather than sort of sit on the waiting list just sort of going longer, you'd put them separately, recognising that they want to come in next year or in 6 months' time, not now.
I completely agree with that, because I think it's distorting your figures.
Absolutely, and actually, you know, making our performance look, you know.
And then my final question, which is another question about, you know, ignorance, is under clinical genetics, you say accurate and addressed through budget setting 2024, a new service approach and move to PPICG. I have no idea what that means.
Okay, I'm happy to explain that. So again, these are patients that I can get, so actually a lot of this activity has already been carried out, so this is in a process of validation and getting evidence of outcome. So we've historically, Jersey's had a contract with a UK provider in relation to this, and it's so we can see that the patients have been referred, have been seen, but we just need to outcome and have the evidence so we can remove them from the PTL. We haven't historically had the budget for all of this, not so this is something that we want to develop, but we have identified some new funds actually at budget setting to allow us to do this in a different way, use one centre where we'll get some efficiencies. So that's what that was referring to.
Because genetics,
this is
to sort of make, do you want to explain?
Yes. So
Patrick, you're an expert in genetics.
Yeah, I might have
but just explain what it is.
Yeah. So this is particularly when patients need screening for areas of cancer. So they might have had someone in their family who has developed a cancer that could also be a genetic element, and obviously it's other people in their family being brought in to be offered clinical genetic screening. So particularly around breast and ovarian cancer, for example. So it's not patients receiving care, but it's obviously that broader offer to allow people to understand what health risks they may be carrying, to obviously give themselves some treatment options. Yeah. But they've been seen, we just need to take them off the waiting list.
No, good.
Sorry, Maxims.
Maxims, thank you. So again, this is, as I was describing, we can, so Tracker Care, our previous electronic system, was a episode-based system. So you're coming in to be seen for outpatients, you're coming in to have surgery. Maxims is a referral-based system which will allow us to assess our performance in terms of referral to treatment, which again is about being admitted, having your diagnostics, outpatients, and then being able to have your whole treatment plan concluded, and we can hold ourselves to account to be able to demonstrate performance in that way. And Maxims does give us that ability. But we do know that the PTL, the waiting list, was artificially inflated as we started to get to know Maxims and use it in a different way. We know that we need to train and support our staff more, and we do have examples of one patient being on 11 times. So some of what we're describing transparently is our actual numbers on our waiting list, but some of those are still the patient on there multiple times. So that's what so actually in the section.
I think you've explained that to us before, Claire, about people are on there a few times. And I think that was one of the issues that we said that why we'd like this report back is to you know, that data needs to be cleansed so that we
Yes.
get a really accurate
Yes,
picture.
we are.
When do you think we would be able to get that accurate picture back here?
So what I can do in next month's report, either in terms of the key PR, is demonstrate how so I've got data where we can see that we're actually reducing those, you know, multiple referrals and cleansing the data, and ultimately will be described by the waiting list being reduced, not only from the actual care and treatment we're providing, but also in terms of validation. But I can present some specific numbers, particularly around patients removed by validation, so happy to do that.
I think, well, I'll leave the timescale with you, make it no more than 3 months.
I'm happy to do it.
But if you come
before
back
then.
to us with
Yeah.
cleansed data, and then we can, I think the other thing I would really like to see in this report is some benchmarking.
Yes.
Because to a certain extent, you know, I might look at this and think, my goodness, that's terrible. But actually, if you benchmark
Yes.
comparators, if you did some comparator hospitals elsewhere,
Yeah.
obviously maybe in the UK, I don't know whether you'd be able to do it elsewhere in
Yes.
other jurisdictions, but if you could do that, and then we can just look to see how it compares, because sometimes, you know,
Yes.
I think we're unaware
Yes.
of some of the
Yes.
barriers that you've got,
Yes,
really.
no, happy to do that, and that
Yeah.
again was part of the rationale by us introducing the 52-week standard, because that is generally
That's an
a
NHS,
metric
it
that,
is.
so we can then
Yeah.
start to benchmark ourselves.
Definitely, yeah, brilliant. Thank you very much indeed. Is everybody okay with that then? Good. Excellent. So,
Oh, sorry, Chair,
Oh,
sorry, just
yes.
to say, and if Jean Elliott's not in the audience, right. But if Jean was here, she'd later on ask the question about when we're able to publish the waiting list data on the government website, because we've been trying to work about that. Do you want to just sort of do an update?
Sorry, I wrote myself a note and then forgot to say. So, again, one of the reasons why we had, I suppose, a lot of detail in this paper was because we know that we haven't had the website that was available to islanders on the Government of Jersey website. We expect that to be uploaded and available by the end of March.
brilliant. Good. Thank you for that. Good. Thanks, Claire. So let's move on now to the workforce report, Bill. You've been given a heads up of one of the questions you're going to get, so you might want to cover that in your opening. But I thought the report was quite clear, so I don't think you need to do it introduce it in detail at all.
Okay, so can I just check everybody can hear?
Yeah.
So what I propose to do copiously is to take the executive summary, pages 4 and 5, as one piece, and then talk about the solutions that are being prepared that refer to recruitment activity in the pipeline, and then to finish off fairly swiftly on some of the initiatives, because I think there's some important stories here. So the metrics themselves, which Chris has touched upon in his Chief Officer report, speak for themselves. However, following the previous report, Workforce followed lines of inquiry, and I think that's the best way of describing it, lines of inquiry about the sources of data that feed these metrics. And one of the things that has been challenging over the last 6 or 7 weeks, certainly for me as a new guy, is trying to understand the alignment of sources of information that will make sense. Those very sources of information relate to ward-based activity, information that the ward managers, senior nurses and the like have regarding what they believe as vacancies, staff in post, what Connect people have as vacancies, and what funded establishment and budgetary information is. Now, on the 8th of March, I believe we're going to have a single, hopefully truthful version, as we call it, of what the vacancy numbers actually will be. But I would project that the numbers which are shown in the metrics there are not too far from it, but not as accurate as we could have them. When we've explored some of the data, that's why it's shown maybe an increase in some of those numbers, because the more you look into something, the more complete, the more accurate that data will become. So the vacancies obviously show work to be done, and I will explain how we intend to tackle that moving forward. The middle ground, which is the turnover and leavers, doesn't show a worsening situation. It's fairly stable, it's not as bad. And for the winter months, that's pretty good positive news. However, the sickness rate has gone up slightly, and even though we don't have a classical occupational health service, we have support from a company called AXA Healthcare. What I'm reliably informed is that the service we get is not as maybe as good as what it should be, and I'm in communication with people at Broad Street to see how that can be improved and how we can have better supporting guidelines on dealing with sickness. The key challenge has been performance management through connected performance, and it's fair to say that in my experience this is unfortunate, but it's also predictory at this time of the year. Normally when you have the first quarter of a financial year, people have to pick up from the performance, the appraisals, the feedback from the previous year. And what we are intending to do with regards to connected performance is to make sure that this is on the agenda as a standing item for the senior leadership team and for the executive leadership team. We've asked for more granular information on this, so fellow directors and myself, we can interrogate, we can review performance figures with people lower down the food chain in each of the care groups and within the department. So this is becoming one of those top 5 issues that will be reviewed consistently, well, continuously by the executive leadership team and the senior leadership team. Again, there's room for marked improvement. So what are we going to do about some of these things? Well, we have had 3 recruiters being seconded over to workforce. We've been under-resourced in order to try and improve some of the recruitment performance. We recognise that this is part of change, not least because while we bring people on board to support the work of the HR consultants, we have to mould the recruiters, we have to change the way that we're working in our style of recruitment, the level of engagement and the timing of that engagement with candidates, which has been too ad hoc. And in fact, when we've done the recruitment mapping exercises with colleagues from Obi's team, we've identified 66 micro steps just to get people from A to B within the recruitment pipeline. So my team and the new recruiters, we have a workshop planned for the 7th of March where we hope to condense that activity, those number of steps, from 60 plus to about 10 or 12, which is manageable. We hope to translate what we want to do, eventually working with the operational managers to make their lives easy, so that we're not keeping going back, challenging, checking and wasting their time. What we want to do is make sure it's easier to recruit. And part of the problem has been is that there's been too many silos operating separately. We've not joined all the dots in the constellation, as I call it, to make it a slicker process. So the time of getting people on board has been hampered by us not engaging in a timely way with the candidates, making sure we're answering their questions. So even if we put the first hook out to advertise and get people attracted, in the past we've lost people potentially because we haven't maintained that contact. We haven't given them sufficient information to want to still come and join with us. And on top of that, our onboarding arrangements have not always been as good as what they should be. So there's a retention element as well. So all of that is like a comedy of errors that we need to actually improve. This will take time. This is change management. This is new working practices. And what I've been trying to do, working to a deadline of the end of March, is to say we'll get the infrastructure right. We'll work with people to employ the new ways of working, so that in a way of under-promising and over-delivering, by 2 or 3 months afterwards we will see the fruits of that labour coming in. I'm not going to sit here and say great, we've got the infrastructure straight, we've sorted it out, we've identified all the issues, that would be ridiculous and it would be less than credible. What I am saying is that between the end of March and say round about May, we will be seeing more green shoots of that progress coming through. It's not what we wanted, but at least we've identified the solutions. We've got now people coming into play. We've got our workshops mapped out, and what we'll be doing with our operational directors is explaining how that process will work. What we will also need are some recruitment champions who will help us make sure those processes are effective. The pipeline at the moment could take up to 100 plus days. What we're trying to do is get it down to about 55, 60 days in total. That will be a great achievement if we can do that. So turning to the other initiative, exit interviews, of course people will always give various reasons for the exit interviews. They'll always say either moving on or there's family requirements or whatever. But we have to delve into that to understand why people leave. We also need to make sure that with induction, we need to reintroduce corporate and local induction days. And in fact, in discussions with union colleagues, they would welcome the opportunity to support that. We have a number of initiatives, such as Refer a Friend, that will be taking off. It will be going live in 2 weeks' time. We would have been promoting that sooner, however, owing to sickness levels within the comms department, we've not been able to get that out into the airwaves as quickly as what we should be doing. In addition to that, regarding the staff appraisal and development, connected performance, we need to push on with this and hopefully get the messages across to line managers and provide the support on that as well. And I think that summarises the fact, to be clear, there's systems alignment that we need to do. There's getting our infrastructure now established, moving forward with operational managers, and there's a raft of other projects that we need to get off the ground. Thank you.
Thank you for that. So I'll ask Claire whether she's happy with the response on recruitment. I mean, I think that's something I can't conceive of 66 separate processes to recruit somebody. That is ridiculous, frankly. So we need to, I mean, it's good that you're working on that, but I think it would be really good to bring that in March. Yeah. At the end of March, we have the People and Culture Assurance Committee, and I think it would be good to bring that in just so that we can have a look at the 66. Did you say it's gone down to about 10?
Yeah.
Even 10.
The aim is to get it to 10, it's not down to 10.
Yes, well, it would be very good to get it down to less than 10 if you possibly could. But anyway, Bev, do you want to come in that? Just let me check that Claire's happy with the response.
Claire is happy. She's
just
currently moving to.
Oh, is she? Okay, cool. All right.
Yeah, I'm happy. I think that's excellent, and I'm very happy to be part of the discussion because this is an issue that faces us all, right across all health services. Very happy. Thank you.
Yeah, thanks for that, Bev.
So thank you, Bill. I just wanted to make a couple of points, really. I think there are some things within our gift now, and there are things about managers getting vacancies out to advert quickly, getting the job descriptions up to date and out to advert. What concerns me is the number of live vacancies is 108, yet we're saying there are 500 vacancies in the organisation. So we're not recruiting to 500 at once. Now, I think we need to validate that vacancy data for sure, but I don't think, I think the speed at which you get the adverts ready and get prepared to replace the person that's leaving is the first point and the most critical point. It also stops you going to a locum and then relying on that locum because you've not got the pressure. So I think it's that mentality which is really important. So I would be looking at that measure to say how many are live and then look at the trajectory around where people are around the shortlisting. Bill's absolutely right, there are too many stages where it can possibly get delayed. But what we can do in our own gift, is really critical here. And I think we know from talking to the execs there are particular campaigns that need to run. We need to run a campaign for healthcare assistants, we need a campaign for mental health, for some varied roles in mental health between therapies and nursing, and I think those are things that have to run alongside the improvements in the process.
I was going to ask about the issue of healthcare assistance, because obviously the statistic in relation to that is not as positive as others. And again, I was going to ask if that could come into the People and Culture Committee to see what campaign we could do around that, because I understand those have to be local people as opposed to people from elsewhere with residency rights or whatever the legislation around that is. So I think that's really important. And yesterday when myself and Tony walked around on the wards, various nurses did say that the real issue they had in terms of staffing on the wards was healthcare assistance. So I've got two people. Let's keep it quite snappy if we can.
Indeed.
Bill and then Andy.
Indeed.
And then Tony.
So in also discussing recruitment and the various challenges with the acting chief people officer for the Government of Jersey, I've been offered additional support by a nurse specialist recruiter who I've met this week. She will provide a consultancy-based service to support getting the nursing microsite further development and getting that off the ground and looking at niche recruitment areas, particularly in the UK. But also she will provide that recruitment specialist time that we haven't got within our limited resources. So I'm welcoming any support that we can get from the central.
Andy.
Thank you. So
use a mic if you can.
Sorry, Tony, I'm still leaving the issue. So the process of getting the advert out in response to Bev's point needs to be part of the process mapping. That's one of the longest processes. To be in a place where we have a job that's been vacated, we can just advertise it. Absolutely not. There's multiple steps that need to be taken before the advert can be placed. So that's the first issue. In relation to healthcare assistance, we've seen a real change, even in the time that I've been here. The number of people that apply for healthcare assistant posts. So historically, within mental health services, for example, if we advertised the healthcare assistant post, we'd have multiple applicants. We have more people than we could recruit. Now we have one or two. And that's in the context of the market growing. So as other care services are established, etc., people have got a lot more choice. So we're currently talking to the central team about apprenticeships and the introduction of apprenticeships. And Jessie and I were talking about it only this morning, because I think that we have to start thinking about some of those routes into our services.
It's not just apprenticeships, it's also the move on from being a care assistant to being a nurse or whatever it is.
Absolutely, and pathways.
Yeah, absolutely, career pathways, brilliant. Tony?
Yeah, thank you. And regarding our trip around the hospital yesterday, Chair, it was great to see so many smiling, positive faces as well, wasn't it, really? People clearly proud to be there and welcoming us. It was really great. I think picking up what Andy is saying as well, I mean, we really do need to be picking up these internal processes that are leading to delays in advertising. What can we streamline there, really? And for People and Culture Committee Chair, on staff appraisal and development, we all know how important that is, really. So what is it that's getting in the way of what looks like a very low level of completed reviews for 2023? Only 17% completed by the end of January, which was the cut-off point. Again, that's not a criticism. There can be lots of issues behind that, but it's worth a look, I think, in the committee, Chair, if I may say.
Yeah. I think we will definitely do that. I'll bet you any money part of it is loading it on the system. Managers actually, I'll bet you any money it is in every organisation.
I think that's.
And I put my hand up. I was never very good at it myself. People had a brilliant appraisal, I'm sure.
we do have to get better on this. It's a sort of key indicator. We're very poor compared to the rest of the government, but again, I know, and Kathy knows, that in nursing, of course, it's done. It's just if you're a ward manager and you've got 35 staff to appraise and set objectives, then putting it all on the the government computer system. So I wouldn't say that number reflects how many's been done. It reflects how many's not been put on the system. But we need to put them on the system, otherwise we don't have that sort of central record. But as Bill said, we've got to improve that and get people used to putting it on the system or supporting them. Because, say, if you're having just completed 35 appraisals, you then think you have to sit down and put it all on this not that user-friendly system. It does make a difference.
Brilliant, good. Thank you very much for the report, Bill, and obviously we'll go into it in more depth at the committee. So next is the Quality Committee. Is Claire? I can't because I'm behind me.
Claire is here, but just due to some of the technical issues, Patrick is just going to give a verbal summary of some of the outputs.
Go for it, Patrick.
Thank you. No, we were really pleased to reconvene the Quality Committee yesterday, chaired by Claire, because it has been a bit of a gap. The key points from the meeting, we discussed the terms of reference, and the first thing we did was change the name of the committee to the Quality, Safety and Improvement Committee to better reflect the function and purpose, and in particular wanting to understand the learning that's taking place within the organisation. The terms of reference has been reviewed, amended, including the membership and those in attendance, and we'll bring them back to the board for approval. We reviewed the quality indicators that we've also looked at today, and there was no immediate concerns for escalation to the board. There were a few papers presented to the committee, one on NICE guidance compliance, and we were able to, the committee received assurance that we've communicated the policy change about following NICE guidance. However, we don't have robust assurance that can evidence it's been followed and that other evidence-based practice is being followed. Once recruited to, this will be a priority for the Head of Compliance and Regulation and part of the Quality and Safety team as we prepare for inspection. And it's an important piece of work for myself and Jessie to concentrate on. But the committee will continue to monitor progress in getting that assurance, noting that it will be a 2-year plan. Escalations and exemptions will be reported to board through the committee, which we've discussed in the exemption process here before. There was a paper on prescribing data, and really Claire clarified what she was hoping to be presented with in terms of the metrics around that, so that will come back to the committee again. We reviewed the medicine optimisation group terms of reference, and some amendments were suggested, and this is a subcommittee of the Quality, Safety and Improvement Committee. There were some concerns regarding hospital versus community prescriptions discussed. There was
just on that point of hospital versus community prescriptions, yesterday, as every single time I've walked by the pharmacist in the hospital, there was a large queue. So it would be really good to kind of know, I mean, not today, but I mean, that issue needs resolving, doesn't it? I mean, Jessie says everybody can have a seat if they want one. I'd be more, which is great, but actually the real issue is there shouldn't be queues anyway, really. So we need to sort that out, Patrick.
The big thing to sort out, Chair. Can you hear me?
Yeah.
It's not a simple thing to sort out because it depends on who's paying. I mean, who pays, whether it's the patient pays and whether it's free in the hospital. So it's actually, I think, more of a political issue. And what we need to do is to work through it and then maybe present some options to the politicians who might want to then make some changes. So that's the problem with this, is you get free prescriptions if it's issued at the hospital, but you have to pay a fee to get it given to you by the GP, as well as a consultation. So there are big disincentives for getting the GP to getting a community. It's not insurmountable, but I think it's something that the politicians may be able to get their head around once we give them enough information.
Yeah, no, I just agree completely with that. About 50% of our outpatient prescriptions are drugs that are on the prescribers list. but because consultants aren't on the prescribers list or hospital doctors aren't on that list, we can't prescribe them to be dispensed from community pharmacies. And that relates to the funding around it, because drugs dispensed in community pharmacies are paid for from the health insurance fund, and that's a separate department of
yeah. So if that's resolved, the waiting.
Yes, and it would be much better for patients, because our pharmacy is constrained in terms of its geography. It's not set up to deal with that.
And I know that when we've spoken to the new Minister for Health and Social Services, that he is very keen to address that issue. Yeah. So it would be good to see that moved along. Anyway, so thank you. Carry on. Are you done?
See David nodding in agreement, who's experienced that problem over many years when you were with us. Around prescribing, there were some concerns around cannabis discussed and the prescription of medicinal cannabis. We discussed the serious incidents. The paper that had been coming to this to board is now coming to the committee. One never event has been noted. There are no immediate safety concerns or any concerns that there are have been addressed, but that will be presented to board after the formal investigation has taken place. We discussed rheumatology, and the committee will receive progress against the recommendations. There's obviously the nominated non-executive director to oversee this, and we discussed, whilst there's been an awful lot of work in rheumatology, it's been overseen in a number of different areas, and we just think we needed to refocus within the committee on the recommendations made by the Royal College. And the other area that's of importance that we discussed was around sodium valproate. That's a drug used for the treatment of epilepsy. It has potential teratogenic effects during pregnancy, so there's a move across the UK, which we will also adopt, to get all women of childbearing age off that drug and onto other treatment, and progress will be provided to committee, though we'll obviously have to work with our colleagues in primary care around that. And I think that was everything that Claire wants to raise.
Yes. Brilliant. Well, I think that's well done that is now up and running. And how regularly will the committee be meeting?
It's quarterly.
Quarterly. Excellent. Brilliant. Thank you very much for that, and we'll get a formal report to the next meeting.
Sorry, Chair. Just for the minutes, can we also say it's and men have to be taken off sodium valproate? It's men and women. So can we just make sure that that's noted on the minutes? Otherwise, we won't be doing the right thing.
I don't think the minutes need to go in that level of detail, but the report that comes to our next committee should say that, if that's okay. Yeah, good. So if we move on then, so the next item on the agenda is on medical job planning. Now this was brought forward because concern was raised at the last meeting about a pause. This report basically gets things back on track for job planning to be completed by the end of October, if it all goes to plan. And I think on that basis, you know, the board should say thank you for reconsidering that issue and sorting it out. So I don't think it needs discussion. Is everybody okay with that? Good. Thank you very much. So that gets us back on track in terms of time. And we are now on the paper on medicine improvement plan, which was on the agenda as acute medicine, but it is the medicine improvement plan. Now that's you, isn't it, Patrick?
No.
It's you, Claire, is it? Oh, sorry, Claire. Apologies.
Colleagues, happy to take the paper as read, just bring out some key points. We continue to have in place our 2 weekly medical improvement groups, so similar to what the board has seen described around our improvements around maternity. So we have additional capacity with both executive and change board colleagues to monitor progress within the care group, and obviously the response per se that met as planned yesterday. We're really pleased to demonstrate progress, closure of some of the particular critical recommendations fed back to us by the Royal College, and there's further detail in relation to the evidence of those provided in the appendix document. I think the key activities, particularly in the last month, have been the ability to advertise the 5 general medicine consultant posts, and so they are active, and we're pleased to report that there's good interest in those roles. Also, again, the ability to secure the capacity that a flow coordinator will bring to support discharging and flow, obviously feeds into other conversations we've been having, and also the fact that the same-day emergency care, so our ambulatory unit, has actually been able to be moved in weeks. So that actually happened on Monday night, which again was a key recommendation from our external physician advisor and support. So I think those are the main headlines. Obviously, we will now then focus particularly on the ambers that are remaining in the 0 to 6 month period. But again, at the Medicine Improvement Group meeting yesterday, there was good evidence now emerging of improvements around our ability to demonstrate within the notes that we've got a routine approach to capturing the assessment, the documentation of the medical plan, and the assessment of those actions with the template. Obviously that's still on paper, but when we're able to implement clinical noting in April via the next stage of the benefits realisation of maxims, then again obviously that will be very standardised because of the templates, and they're all being created with the different specialty teams. So I think those are the main points that I wanted to raise, and obviously we're continuing ultimately to close the recommendations that Royal College.
Sorry, just to... it's good, isn't it, that we're out to advert for the 5 physicians.
Yes.
But of course, just sort of linking to what Bill and others have said, you know, about if we're getting good interest, which is again excellent, let's not sort of screw it up from the point of view of not keeping those individuals sort of on board and warm, yes. That we don't lose them, because we're desperate for that input.
Yes. To reassure some of the individuals that are interested are actually here already working with us as locums. So again, that's really positive that those people are working with us and they want to stay and they want to contribute to leading these areas. And even better, once they go through obviously a robust interview process and are appointed, the recruiting timeline will be very quick because they're here already. But obviously we'll let the interview process.
Assuming that they are the best candidates, of course.
Assuming that they are the best candidates.
Yeah. Okay. All right. So Julie.
I just wanted to build on the issue of the need for the 11 funded posts. Obviously we have the 5 in recruitment. It's very encouraging to hear that there's good interest in that. But I just wanted to ask about the 6 unfunded posts and to ask what process is sitting around that. I assume there has to be a bid made, but does that have to wait for the next government funding round, or is there some other route that we can take? Because clearly it would be good to have the 11 and have a sustainable medical model in place.
Yeah, just if I start and then Obi, who looked very worried, will continue. So I have to, yeah, there isn't any funding for those posts at sort of the bottom line. I don't think we're expecting that this year there will be a sort of process where or certainly a formal process where we can secure additional funding from government. So it does leave us with a real challenge. So these are really important posts that we want funding, we don't have the funding for, and I'm not sure there's a process in which we can now follow this year to be able to secure that. But Obi, is that what's your...
Yeah, that's correct. The formal funding rounds have closed, so if there are any specific cases, then it's on a case-by-case basis. We can, certainly doesn't stop us from going and presenting a case, but there is no formal process on that funding being available. It is on a case-by-case basis.
So as a follow-up, do we have a contingency arrangement to manage that gap?
I think the only contingency we can have is
no, really, yeah. It's we need that funding. The only way we can find at the moment, absent of a process, is to reduce something else to pay for it and cut something else to pay for it, reduce another service to pay for it. So these are difficult decisions that, as the senior leadership team and board, that we're going to have to make at some point. about what we can fund and what we can't fund.
I think it's important as a board we understand what those compromises are.
Oh, absolutely. Yeah, these are difficult
and
decisions.
the impact on patients.
Yeah.
And I think that sort of just supporting what Chris is saying, I think as a board that I think underlines the difficult choices that we have to make within budgetary constraints as we find things which are quality deficits, not productivity deficits, but quality deficits. But with the funding that's available, we need to be able to then champion that to correct some of the historical issues that we find. But that's a management challenge, and so we have to make difficult choices as we go along. We're doing that all the time, and this year is going to be particularly
not a management challenge that's unique to Jersey.
Yeah. It's particularly difficult this year.
And I have to say, you know, 5 additional consultants, you know, as a percentage of your existing consultant base is pretty good, actually. So, yeah, okay. Anything else from anyone else on this report? No, but well, it is good to see that things are progressing on this as they are, so I think we should all thank you for that. So if we move on now, we have the mental health external review implementation plan. Andy, so if you could give us a high-level and brief introduction, thanks.
Thank you, Chair.
Andy, yes, usually.
So this is a really well-timed 2-year update on the implementation of the external review of mental health services that was commissioned in 2021. And folk will be aware that the review had 10 sets of recommendations relating to the safety, quality, management and development of mental health services. I arrived in the beginning of 2022, that my post was created on the back of this review, and we set about establishing a very clear plan for mental health services, an annual plan, which aimed to address the recommendations and a raft of other things as well. Clearly, a vast amount of the underlying change that was required was cultural change. So will take longer and needs to be sustained. But there were some very early wins. They were around restructuring the services actually, and restructuring the leadership team, putting governance structures in place, introducing physical health checks for people with mental illness, developing a partnership board. There were some things that we did very quickly. And we really focused in the first year on redesigning community mental health services, and that was because there were real concerns about access, how quickly people got into services, how often they were seen, what was then happening to them, and we did a load of engagement work with service users and carers to agree the priorities. The community mental health review was a whole-scale change. It involved over 120 staff, went through a management of change process, but it left us with a clear structure for community mental health services, for operating arrangements and particularly KPIs, so we could start to measure. I'm hoping that what this paper then does is show in detail, recommendation by recommendation, the actions that's been taken, where we are today, and then in particular I've incorporated the evidence. So from an assurance perspective, the evidence that demonstrates that where we say that we've done things, we can show that we've done them and the impact that they've had. And you will see that the summary of the paper is that the vast majority of the actions have been implemented. But unsurprisingly, there are still some areas where we have further work to do. And there's just a couple of specific things that I want to call out. So the first is the introduction of the CARF, the Care and Recovery Framework, which was long overdue and is the framework by which we would deliver secondary mental health care to people with serious mental illness. Now, it was relatively easy to implement the framework, but actually what we're now doing is auditing how is that working, and we're auditing it from both a process perspective but also from a quality perspective. So at the end of last year, the leadership team of mental health services met with each of the care coordinators who has responsibility for coordinating the care of a group of people in the community, and talked to them individually, not just about how often are you seeing people, are you completing the risk assessment, do we have a care plan, is the service user involved, but also talked about what are you doing, what are the interventions, what's the quality of the work. And we're currently drawing that together in a paper that sets out some further work for us to do, particularly around how frequently people are seen and how clear we are about the outcome of any intervention. We developed a mental health partnership board because one of the key conclusions of the external review was that there was some good work going on, but actually we didn't have a clear system. Mental health services didn't work as a system, and that includes our third sector partners, police partners, prison, other areas of government. And I'm really pleased to say that in the last year particularly, the Partnership Board has started to feel like it's working. It's commissioned pieces of work, including the co-production policy that we're now using. And this year, for the first time, we have developed some system KPIs for mental health services. So KPIs that are going to be measured across the whole of the system. So whether you're being seen in HCS services, or whether you're being seen in a mind drop-in centre, for example, or you're receiving mental health care in the prison, we're going to be measuring the same thing. And that's such a step forward, I think. We are a raft away from where we were around mental health legislation. We now have a set of new procedures. We've published through the Minister annual reports. We have a highly competent head of mental health legislation who keeps us on track in terms of making sure we're following the law. And we have a very good multi-agency assurance group where each month we meet and look at all use of mental health law, all use of restrictive practice in our inpatient services. So we're able to quickly identify and resolve issues as they arise. And we are also in the process at the moment doing a piece of work looking at changing the law, because some aspects of the law do need to be adapted slightly. So we're going through a law drafting process to sort that out. The place that we're most focusing our effort this year is around inpatient services, and that's both the quality improvement programme, looking at the work that we do when people have to come into hospital, and we're coming at that from a variety of lenses, but also moving Orchard House to Clinic Canal, which I'm hoping will occur now at the end of April, but it's been a continuously delayed process. That provides us with an opportunity of a better physical environment. It also provides us with an opportunity to introduce an Article 36 suite where people that are detained by the police under mental health law can come and be cared for by mental health professionals rather than taken to A&E, which is again long overdue. That's a summary of 2 years' worth of work, and there's a lot more detail in the paper. I'm proposing now, we've been reporting against this particular review specifically for the last 2 years on a regular basis. We have nonetheless an annual plan every year for mental health services, which is monitored through the normal governance frameworks. So I'm proposing that we close down monitoring of the external review as a separate entity and now bring this back into business as usual. I just want to end where I started. A lot of this isn't just about systems and processes, it's about culture, it's about change, it's about resetting expectation, and you know, I'm very clear there's still a lot of work to do. We're not yet where we want to be, but I would really want to congratulate the leadership team in mental health services who have focused and have actually achieved, when we collectively think about it, a large amount in the last 2 years.
That's brilliant. Thank you for that, and congratulations on that. And I think we will all, I'm sure we all agree that you should just business as usual. There's definitely. You were just going to give us an update on learning from the inquest, yeah.
So this was the tragic death of a man who died from neuroleptic malignant syndrome, which is a very rare but potentially life-threatening reaction to antipsychotic medication. And at the time, following his death, an external review was commissioned which made a series of recommendations, and those recommendations were implemented. There were some very immediate actions that were taken, and there were some that are still in train. The finding from the inquest was very similar to the finding from the SI report, actually, and particularly the issues that were identified were joint working between mental health services and the general hospital. So when someone has complex physical health needs and mental health needs at the same time, how services work together to ensure all of that is being met in its entirety. This is something that Claire and I have been very worried about for some time. We have started a piece of work jointly between the hospital and mental health services. There's certainly still a lot of work to do there, but that's certainly one of the key findings. The finding of neglect related specifically to the failure to identify that this man was dying and send him back to the general hospital. He'd been transferred on a number of occasions between the general hospital and mental health services, and in the end remained in mental health services, but actually his physical health indicators suggested he should have been transferred back to the general hospital. and that was the issue that the relief coroner identified as being the issue of neglect. There were a couple of other issues that very much came out of the inquest. One was around clinical documentation and people making sure that they document decisions and they document rationale for decisions and not relying on, I had a conversation with someone and this is what we agreed, but there being no record of that conversation, because clearly that's an issue, a professional standards issue. And then the other issue related to nursing staff and particular issues around nursing staff and when they're working continuously with an individual patient, frankly not being on mobile telephones and other media when they should be caring for the patient. I've written to every member of staff in the mental health services setting out some of the issues that were found from the inquest and reinforcing some of the issues that were found in the serious incident report. I'm pleased that the coroner specifically identified the work that we've done in the last 2 years, and she was satisfied to the extent that she didn't issue a prevention of deaths finding. She was satisfied that that work is moving in the right direction, and I think that's correct. But clearly, this was a terrible incident, and met directly with the family on a number of occasions, and we could not apologise enough for some of the gaps and omissions here.
Well, thank you for that, and very sorry story, actually, very sad. But what's most important now for us, obviously the family will never get over it, but for us, what's most important is to learn those lessons. And it's an issue, and it's not just an issue on the island here, it's an issue everywhere, that link between mental health services and general hospital services. And just yesterday we were walking around the wards. I mean, a couple of nurses dealing absolutely brilliantly with dementia, a lady with dementia. But actually, that just constantly distracts people from the general medical work because they are dealing with patients with mental health diagnosis. And I think that's something obviously that you're acutely aware of. It's an issue in relation to this, but I think at some point when you're ready, it would be good to just understand how we are making that link up better, because it really is a matter of concern, not just in Jersey, as I say, it's in every hospital, every general hospital where the number of people with mental health issues, whether it be dementia or other, more violent kinds of mental health portrayals, are there for medical reasons but are detracting everybody from the medical staffing side. So
I'm pleased to say we have an established working group that I chair.
Oh, brilliant.
Jessie sits on. We have representatives from both mental health services and the general hospital, where we're looking really specifically at the care of people with dementia and delirium within the general hospital and how we do that together, because it has to be joint enterprise.
Yeah. Well, that would be good. I think it would be good to get something coming here about that once you're in a position to so do. I don't want to rush something or anything, but I do think it's an important issue that we've got to get on top of. I know other hospitals that I'm involved in, it's a major issue for them as well. So, yeah.
Sorry.
Yes.
Those guidelines.
Well, I think within the maternity data, there's been a reduction in the number compared to last year. That's one thing. We'll never get that down to zero, as I understand it, on obstetrician. But there's always that risk. What we're seeing, because we have been asking any massive obstetric hemorrhage to come to the serious incident review panel to be considered to be Claire as an SI, we're seeing the way that it is managed has markedly improved, and it's a very significant drop in the number of MOHs that have been declared as a serious incident. That's good.
Okay. Anybody got any specific questions in relation? We do see this very regularly, so and we walked around the maternity ward yesterday with colleagues as well. It was very calm, actually, wasn't it? Any issues from anybody? No? I think on that basis, thank you very much for the report. We'll move on now. Is the HCS annual plan, and again, given this is the annual plan for a year that we are now 3 months into, I think we should work on the basis that this is effectively largely agreed anyway. So if you could make the introduction brief, Anushka. I do think, however, we need to think about the annual plan for 2025 and getting that into the system somewhat earlier, and having some stronger ministerial input into that as well as board input. So that's just a general comment on that. Thanks.
Yes, thank you, Chair. So just for noting this annual plan, particularly I think important as a joint overview of a number of improvement areas, but also explaining that the accountability, the structures, from the Minister down to the operations. So I think that it will act as a good reference document as well, hopefully for the public as well. Just to highlight, there are 2 items in the plan which have basically delayed a little bit this coming to board. So we want to include the ministerial priorities which have been set for this year, but due to the change in government, of course we're just awaiting for the current ministerial priorities to be agreed and published. I do hope that we will have this all ready for the March board, so we can basically update the document with the ministerial priorities for this year. The other item is the board assurance framework. It's an item we have been working on. We discussed it as a board already informally, and this will be more operationally the key objectives being set by the board, what to achieve, the key risks to achieve these, what are the controls, mitigations being put in place. So this should come to board in March as well. But apart from that, I think it's what it is, and it shows as an overview the large number of focus areas for change, improvement, but also things like the digital programme I included as a reference.
Yeah, I thought it was very clear personally. Thank you, well done. And I actually really liked your action plan because it was very clear about the accountabilities and the timescales, etc. So I just thought that was a very, it was a good action plan. So thank you for that, Julie.
I'd like to endorse your comment. I do think it's very clear and accessible document.
It is.
I also thought that this was a very helpful diagram to show just the sheer complexity of the undertakings that fall within health and social care. I'd like to make an observation and a suggestion, if that's okay, Chair. The first is an observation, is just to say, looking at that diagram, I was really quite taken aback by just how fragmented our small system is. And one of the drivers in most health systems across the world is for more integration, recognising that, as I think has already been said in this meeting, patients don't recognise individual organisations and boundaries, they just have needs which need to be met. And generally speaking, it's when there are lots of different boundaries in place that people's needs fall through the gap. There are a lot of services here which now sit outside of health and social services, which in the past sat within it. I'm not to say that that should be the way it is, but I think it does give us an issue around how we work as a whole system. And I think the reference to the Mental Health System Board was a really good one, because I think we need to do a lot more of that to ensure that we are managing those gaps and reducing the overlaps and the omissions. On the theme of omission, I do think there is one important area that is missing from this report, and I have mentioned it to Anushka, which is that we actually spend, as a health system, £50 million almost on commissioning services that we don't directly provide ourselves. And that is a number of contracts on island with mainly third sector providers, and a number of contracts off island with tertiary providers, and then a number of individual packages of care that we secured for people with social care needs, complex social care needs. I do think a value of £50 million, recognising that there's a lot of work does go on within the department, and I know that Claire and Andy are particularly on top of this, but I think as a board we need to be cited on and able to take assurance on behalf of the public for the services that are commissioned to not directly providers. So I think a section on commissioning, just setting out the dimensions and some of the key activities would be a helpful addition.
Yeah, that's a really good point.
Yeah, no, I agree, Julie. That sometimes we, and maybe the public forget that, of course, we're not just a provision organisation, we do commission services, so in other jurisdictions you'd have separate organisations that would do that, and now obviously we're too small to justify that, but there is a lot of activity that goes on around ensuring health provision for islanders, both from the UK and with the third sector by and large in Jersey, that has to be managed by the infrastructures in HCS, and part of my responsibility as accountable officer to ensure that that happens. So I think that's a very good point. I think you're right, that diagram is a good one, isn't it? It's a good slide, and one of the things that the Minister of Health and the health team have agreed as part of the ministerial priorities was the priority around establishing an island health and care strategy, which we desperately need during the course of this calendar year. I think, you know, officer colleagues and indeed talking to the ministers, and I'm sure no one would disagree really, is that, you know, part of that strategy has to be how we resolve the complete disconnect that we have for as I said before, a population of 100,000 people. So having a strategy that brings and ensures integration, you know, both of public, private and third sector is critical, I think, to good services for the people of Jersey. So absolutely agree.
Tony.
Here. And yeah, building on what Julie says, yeah, when a number of us have been talking about the out-of-hospital side to this, the out-of-hospital strategy, which commissioning is a key, well, not necessarily the only, but it's an absolute key component. So yeah, I like the way the improvement recommendations are set out on that one single sheet as well, because you really can lose the wood for the trees with a whole string of reporting on sometimes overlapping things to different groups and so on, really. So that's, I think that's very helpful. And yeah, next year, to back up what the Chair's saying, I'm looking forward to early involvement in shaping that in line with our contribution to delivering ministerial priorities. But I think this is well laid out and very good, so thank you.
Okay, so I've just been given a question from a lady who
I don't think we need it.
No,
we
it's
can cover
later.
it at the end.
Oh, it's later. Okay,
Yeah.
okay. I thought it was very specific. So
No. Sorry, so it's my fault.
Good. So I think on that basis, Anushka, obviously, as I say, we are a couple of years in. I think the main concern from the plan for me would be, and we do need to have this public discussion about this, is the financial recovery plan, which is referred to within. And as you said earlier, Obi, you know, you're confident that the recovery plan will be delivered overall, but at what point in which year it's delivered becomes more of more of an issue of concern, really. So I think that's you know, to the annual plan, you know, if all goes well and finances are there, should be delivered. But if the finances just go skew with, then that's going to make the plan really struggle to deliver at all. So I just think we need. It's stating the bleeding obvious, to be absolutely honest, but I think it's important to do so regardless. So is that okay by everybody? Are you happy with that?
Yes.
We note the plan?
I will update that with the commissioning section and also
Yeah, I think the other, just a really tiny little point is you refer to a high sustainable workforce. I think you mean a high performing. Yeah, I didn't think they were all high on something. Brilliant, lovely. Okay, so we'll move on to the next report, which is Be Our Best. So you're doing that as well, are you? Anushka, over to you.
Just we had the detailed report at the first board meeting, quite in detail against all the recommendations. This is the review of clinical governance arrangement. I take the report as read. This is an annual review and a summary of the achievements so far. Now, the key purpose of the report is to give that overview, but also to highlight that we have made achievements on key structural changes and governance changes which were required to move HCS forward, in particular, namely establishing this board. So this board now being in place was a key recommendation to strengthen governance, plus a number of other areas which I've highlighted, additional resources and expertise. So the change team has been brought in, and Chris may want to highlight some of that as being part of the change team at the beginning and leading through this change over the last year. NICE guidelines have been officially adopted, and we've heard earlier a process process going through to ensure they are being adopted, but also any extensions to the guidelines are being recorded. Freedom to speak up Guardian, we have a Freedom to speak up Guardian now permanently in place, massive improvement. Private patients, a strategy has been developed, and a number of accountability framework and assurance reporting mechanisms have been developed operationally, but also as part of the board going forward. The assurance committees play a key role. Independent feedback on patient experience. The PICA survey is now an annual survey, so we're awaiting the results. Hopefully we have them coming to board soon. And overall, the key recommendation was throughout the review, clarity on roles and responsibilities. So that has been established, particularly in the operational side, but also in some areas of quality, safety and quality improvement. Another item which was recommended particularly in response to the review by the then Minister, to establish a strategic health policy function. We didn't have that before, so a number of key areas where we need strategic policy advice, which the department can't or shouldn't provide as the lead. That function has been established and has been agreed as part of the 2024 plan, government plan, to be recurrently funded. Patient focus was particularly for the Minister, and a part of the report, key area of focus, and various projects have been implemented through that, including, of course, the cultural change program, because with that is the key thing going through. Workforce, we are receiving reports regularly on recruitment, number of activities have been done, plus, of course, the finance recovery plan has come out of it, and lots of other activities. So this is an overview of what has happened since the publication of the review, but also to say that the program governance, which was established to oversee the action planning, the monitoring, the tracking of the recommendations, has been in place over this period of time. Now, it is recommended to, a little bit like with the mental health recommendations, to stop these individual reports, but now having a board in place who actually sets the priorities and says these are the actions to follow. We've now used the existing governance with assurance committees and the board to set objectives and to follow through recommendations and actions. Whilst some of the activities, particularly around quality and safety, are in a BAU process, but will be monitored through the assurance committees.
Good. Thank you for that. Has anybody got any immediate comments about it? If not, I'll just make a comment. Which so all of this activity and the change team, etc. You know, nobody would disagree with any of it and what's happening. But in my mind, I just want to really know, how can we be assured it's really making a difference and the organisation feels different as a result? And I'm talking about culture really more than performance outcomes, because we can monitor all the raw data and the performance outcomes, but it's the feel of the place that we really need to understand. And that is very difficult, isn't it, to actually have any indicators or a dashboard about that. And I think we need
not
to
impossible, Chair.
Well, tell us how it's going to be possible, Chris, please.
Well, obviously we have the Be Heard survey, but again, that is a government one. There's only every X years, so
it's not what we want.
no. Cheryl and I have been with the team looking at pulse surveys, so far fewer questions. The Be Heard survey is an enormous sort of exercise, but to establish some pulse surveys so we can ask some key questions on a far more regular basis of staff, just to get a sense and trying to measure the baseline. And of course the baseline is probably the Be Heard survey from last year. So that's one way. I don't know, Cheryl, if there's anything else you want to say.
Shall I?
Yeah, use a mic, definitely.
I think one of the key measures is about engagement within the organisation, and we know that there is a positive increase in engagement. So this is not just about people that respond to a survey. This is about people who are engaging in events. So if we looked at our team talks, which is our monthly pulling together as many people as they feel they want to kind of take part in an hour where they remotely meet with the chief officer, they get an update of developments that are happening across HCS, but it's an opportunity to feedback and ask questions. We're noticing that month on month we're getting an increase of people who are attending those sessions. We have a number of different engagement indicators. So we have a number of events that happen throughout the year. We have a reward and recognition event that involves people nominating staff across HCS, and we're noticing that more engagement is happening from those that would typically be seen as hard to reach members of staff. Those are maybe our staff that are paid the lowest grade and typically don't have English as their first language. So we're needing to think creatively about how we can build forums up for them to be able to have their voice heard and opportunity to feedback. But also our medical staff who have traditionally not engaged as well as other professional groups, so working with them to enable that voice to be heard. So I think we just need to look at how that is. It's a whole system approach. It's not a quick fix, but we're definitely on a trajectory that says that we're moving in the right direction.
So I would agree that all of those initiatives that you said are good things to do. I mean, I do think the annual awards ceremony is absolutely brilliant for those who go, but there's a lot of staff who don't go, and you know, some people kind of can be quite cynical about that. I knew one organisation where the main issue about the staff awards ceremony was what music the chief executive turned up to, you know, to present the award. So, you know, it's got to be something that the staff genuinely think this is our day rather than this is the organisation's day. So I think what I would be really keen for us to do, I know Bill's going to come in, but is to think about a dashboard which we could put together, which gives us some real genuine feedback of how this organisation feels different. So I know that's not easy and it's a challenge to do, but I think we've got to do it. Sorry, let Bill had indicated, Cheryl, and then you can come back.
I think a simple way of beginning to measure the effectiveness of the changing culture, certainly from my point of view as a new starter, was that I did wonder whether or not myself and Cheryl were going to be kept busy by the Freedom to Speak Up Guardian, and it's always a positive thing when you start to have that interaction with the Freedom to Speak Up Guardian, and a number of cases have now started to come through that Cheryl and I are looking at. They range from a variety of areas that kind of indicate that that freedom, that opportunity to actually have a conversation and that it is being pursued, shows that transparency in a more relaxed way, that things will be followed up in the appropriate way. So there's confidence coming through there, I think.
Okay. I think that's right, Bill, with the sort of all the freedom to speak up, but also, of course, that's not the only way that people speak up. You know, people come to me to have a cup of coffee and talk about their experiences they do with other directors that I'm aware of in sort of confidence. So that is an indicator. You know, I sense that people are more willing to speak up. Some people aren't still, and that's understandable. And you know, this takes time. But I think those indicators show that you mentioned, and I would just remember you saying that for the staff awards, which happened last year, for the first time sort of in record, we were actually seeing doctors recommending doctors. Now, I'm sure that was always the case in gastroenterology, but this was to the people that organised it was an unusual thing. So I think that is quite good. I think we need more doctors to turn up to the event, but it was I thought that was interesting.
My own organisation that I worked for, you weren't allowed, you couldn't be nominated unless you were nominated by more than 6 colleagues. you know, so it was not about managers nominating somebody, it was about colleagues nominating.
Yeah.
So it's not about favourites and all of that. So yeah, it's quite important. Cheryl, you wanted to come back?
I just very to follow on from the point that you raised. So our main objective is to create HCS to be a great place to work. However, talking about the dashboard, that is something that has been in progress for the last 2 months, working with the head of informatics and creating what the key indicators need to look like, and what that might look like for staff in terms of it being a great place to work, but also for patients, because we're actually delivering all of this to ensure that we deliver the best and high quality care that we can do.
So the dashboard would not just be internal focus, it would be external focus as well. So this place feels different is what I want us to be able to see. So if we could take that away, and then that needs to come back here, because I think that's something as well that will be really important to ministers as well as, you know, ourselves, because we can do lots and lots and lots of activity and actually nobody feels any different at the end of it. What's the point? Yeah. So, okay, good. All right, so at that point then, I think we've come to the end of this formal agenda. So we've come to the point at which we ask for questions from members of the public, and of which I have one I've already got.
Mary Venturini, we've got your question, but I don't know whether you would rather vocalise it than just read it out.
Yes, do please, Mary.
Why not? I'm sorry, I wrote it in because I didn't know whether I was going to...
Yeah, no, that's
fine. It's this patient experience.
Mary, because this is public and it's webcasted. Sorry. Thank you.
Yes, is it working?
Yeah, it will.
It's patient experience that I'm really interested in. We've heard a lot about doctors, we've heard a lot about staff. We've heard about the Speak Up Guardian, which is basically for the staff.
Yeah.
Now, I would like to see some easy, well-publicised system for patients. I know, Chris, you've said the number of patient reports, etc., or reports from patients is going up. But this is you only see the tip of the iceberg. We see a huge lot more, because patients and their families really don't want to go through a long process. I know there's PALS. I think there is still no manager for PALS, but I'm not sure about that. But no patient who is really suffering, nor their dearly beloved, wants to go through a whole lot of fences, discouragements, a long time, and they're not having any faith in the process at the end. This has happened to me long ago. I still remember it, and I just gave up because I'd been through I don't know how many hoops, and I still got the unsatisfactory answer. Everybody, the staff closed ranks, the system closed ranks. I gave up because the only thing that was left was a legal process, and I wasn't going down that route. So I would ask you to think about a Speak Up Guardian for patients, and to publicise it really, really well, because that's what we need.
Jessie?
Please, we are the people being looked after.
Yeah. So thanks, I think we've definitely heard you, and we've said we'll take it away. Claire's made her contribution well. I've got 2 more people who want to come in, Kathy, and then, Tony, and then Tom.
Thank you, Chair. Something I know the Chief Nurse is already looking at currently is in response to Martha's Rule, and that was the rule that came out in the United Kingdom, due to be implemented April 2024, and that gave families, relatives, carers that 24-hour access to information and somebody to hear from them. And I know that is work that's actually currently ongoing with the Office of the Chief Nurse, which, as the Chief Nurse has already alluded to, we need to have that adequate marketing campaign. Now, marketing is the wrong word, I do apologise, it needs to be about a publicity campaign. But clearly, when we look at the heart of what Martha's Rule says, I think that speaks to the heart of everything we've talked about there, which is very, very much high on the agenda for the Chief Nurse.
Okay, thank you. Tony?
Yeah, I think this is not dissimilar to the previous discussion, Chair, where you were talking about the importance of feel, really. I mean, we can, it's quite right that we focus on the best processes we can get in place and we've got lots of experience between us to address what you're saying. But it'll never be completely ticked off, and we've got to be really vigilant on this all the time. If we're serious about the connection with people who use the services from the patients and so on, you know, we need, again, that word humility, recognising that we've got to keep addressing this all the time and listening very, very hard.
Yeah, absolutely. Tom, I'm going to give you the last word. So, Dr. Ng. Yes, that is so.
Well, I want to say it's great that we have an advisory board formed. I think it allows open transparency for people just. And now that I've retired, I'm one person who's objective. What are the many topics here that I've been hearing today? I think the one thing that I really want to highlight is recruitment and retention. I announced my retirement 10 months before the SCB approved funding for my replacement. And that is one thing that needs to be addressed, because obviously my retirement, my funding is already there, it should be immediately refunded. Once a consultant person appointed, there are stories of them waiting at least 9-10 months before the offer has come through for them to start. We've had, in terms of healthcare assistance, we've had a campaign which cost about £500,000 advertising for healthcare assistance, and I think we only had 7 applicants, or successful recruits from that. So we need to do things differently. Interviews, exit interviews are very important as well, because I think it's important to know why people leave the organisation. And to answer David Garada's question about why physiotherapy wasting time have gone up, is because I believe six physiotherapists resigned en masse about a year ago, and we don't know why. I know why, but I think it's important to find out formally why. Also, we have many locums who enjoy working in Germany. They get paid locum rates, which were 3 times higher than the standard contract. And as a consequence, when they do apply, they want similarly high remunerations, which we can't do. And so we need to perhaps look at the pay structure of consultants, A, to retain them here, but also to attract them from elsewhere. Because there are issues with the NHS, with consultants striking and doctor strikes. And so basically that's my only major point for this talk.
Thank you very much for that. Those points. Well, and again, we'll take those away. So, there's one other person who would like to come in. I do want to give you the last word, to be honest. Yeah. Do you want a microphone? No.
It was a comment for Claire over there. I just had surgery, so I went through your system, had pre-assessment, didn't get told anything apart from they went through everything. I knew I had to stop my blood thinner 2 days before surgery, just as well. The day before surgery, my postman in the afternoon delivered my letter which stated, please stop your blood thinner 2 days before surgery. Had I not known, I'd have turned up to hospital, I would have had to be cancelled.
It's a very good example.
I think that's a perfect example of what Claire was saying earlier in terms of the poor communication. But it's brilliant. It's
these things are actually happening.
No. Thank you so much.
And I've been waiting for this operation, ironically 12 years, but I pushed for it this year. You know, it's ridiculous. It could be down to the postman, it could be down to HCA, I don't know.
But whatever, it's not good enough.
It's not good enough.
Yes, and that's the point.
I should have actually been told of my pre-assessment, really.
Yes, you
but
should.
I wasn't.
Yeah.
I agree.
Okay. Yeah. So I think that's absolutely a brilliant example of what we were discussing earlier. So thank you very much for raising that. It really brings it to life. I don't think I've got anybody else indicating. So,
the lady.
Oh, the lady over there. Oh, I apologise.
Just very briefly to allude to one of the points you made. I'm an ex-civil servant. I didn't have an exit interview. I know people in staff who who've left very recently, they haven't had exit interviews.
So that's also interesting to hear, because it's not HCS that runs the exit interview process, it's the government, isn't it? And I wonder whether that's something to escalate, and now that we've got our own HR, can we do it ourselves? I think that would in some respects be a bit better, but anyway, I think we need to take that away as well, because I think we should just be doing it ourselves personally. Thank you for raising that. Tom, our new chair.
Right, I'm going to take a microphone. One of the reasons for making a point about the microphone is I'm deaf, and while actually I've done quite well picking up from everyone, I know it's actually quite important to think about it. There are lots of things I would love to say, but I'm going to hold my fire. But there are two specific things. One is to thank Carolyn for chairing this meeting, because you've done it, you set a very high standard, and it did allow me to sort of scribble furiously as I was taking things here. But I want to come back to the issue I listened to patients, because the way that you describe it here is that an awful lot of work that should be done. I want to be very careful about what I say here. One of the responsibilities I had for 8 years was being responsible for Broadmoor High Secure Hospital. And to be honest, I suspect the patient is listened to more, and the patients there know how to get the voice of the hospital than I suspect happens in an awful lot of acute hospitals, not just here. And I think historically, actually, in my circles I've chaired an acute hospital and a mental health trust in the past. Mental health tends to be a little bit better, in my experience, because of the nature of the engagement that they have with the service user. But in terms of where I sit, I'm passionately rooted to getting and hearing the patient voice. This is a part-time job for me. It's 2 days a week. And one of the other things I've just been appointed to in my professional life is to chair a thing called the Legal Services Consumer Panel in the UK, reflecting my personal commitment to making sure we listen to the consumer. So a thing that may strike fear into the executive team, because I'm going to hold us collectively to account on it, and maybe a hostage to fortune for myself, a lot of my own back, because you guys can come back to me when I've failed to deliver on it. But actually making sure we listen to the patient back there is absolutely central. And while I wouldn't want to make any other commitments on day 2 in the job, that's one where I hope that if we look back in 12 months' time, that we will feel we're doing not necessarily a perfect job, but doing a bit better.
Thank you for that. Thanks very much for that, Tom. So we look forward to the proposals next in March. And on that basis, thank you everybody for coming today. Thank you for everybody who's done the work for the meeting. We never ever thank Emma, and we should thank Emma, because Emma does all the, and Daisy, they do all the preparation. So thank you to you both. And thank you. Could we reconvene for our part 2 meeting, our part 4, part B meeting? Could I suggest we reconvene at 12:15? Thank you very much, everybody. Bye.